Okay. So last time we spoke, we talked about all of the complications, giving birth and different things that we need to look at. And now we're talking about postpartum adaptations. What should we be looking at immediately after birth, right? After the stages, after the mom, after everything came out, the baby's out, the placenta's out, and now we're looking at the mom, right? So immediate postpartum concerns, especially for the mom, is that the problem is that um, there's a huge risk for postpartum hemorrhage, right? So the uterus starts to begin this process of involution, which is normal, right? It's when the uterus returns to the normal size and it starts shrinking down, right? Because it was pretty enlarged so that the baby, could come out. And as a result, it starts to shrink. But here's the thing, right? If during this process we have a risk for hemorrhage, so we start to check the uterus very closely after the mom gives birth. So, right after birth, the fundus should be at the top of the uterus, should be at the umbilicus. You should be able to feel the fundus or the top of the uterus at the umbilicus, right? At the belly button area. And there could be lochia, there could be bleeding that occurs after delivery. So we're looking at all of those things, but we want to look at how much bleeding, right? If she's saturating 2 peri-pads in 1 hour, she's hemorrhaging. That's not a regular bleed. So we need to assess how much bleeding and where the fundus is, right? It should go down over time. We also want to repair any episiotomies or lacerations. We said that during birth, we could cut the rectum open a little bit, and that can be very painful. And that's something that we're going to have to treat, right? So we want to provide comfort for that, such as ice packs to decrease swelling from the pushing, especially to the perineum area. We want to clean it. We want to assess for pain, give warm blankets. We want to clean her all up and make her feel comfortable, right? And we also want to promote family attachment. One of the most important things when a baby is born is to promote bonding between the mom and the baby. That's why I said one of the first things that you do when a baby's born is do skin to skin with the mom and the baby so they can bond. And we should also provide breastfeeding within the first hour to 2 hours of life. We need to get the baby fed. Okay. Now, after we do all of those things, right? Our priority for the mom is, like I said, that uterus. We need to look at the uterus. So, speaking more about what happens to the body, let's talk about physical adaptations, the involution. We talked about this. We talked about over time, it's going to start shrinking, right? And it's going to immediately after birth, going to go down to the fundus or the top of the uterus at the umbilicus, right? It should be firm, right? It should not be boggy, right? So here's the thing. If they have a boggy uterus, that means they are bleeding, okay? So if they are bleeding, they're going to have a boggy uterus. And remember, we were talking before we give Pitocin, right? Right after that, right after the baby is born, right, to help prevent postpartum hemorrhage. That's one of the things that we do, but we look at the uterus tone. We also look at the location and the height of the uterus. So we're looking at, right, as soon as baby's born, the fundus should be at the umbilicus, right? And it's going to descend 1 centimeter every day. And the uterus should be midline. Now, the reason the uterus might not be midline, which is something I want you to know because it could be an exam question, is if the bladder is full, it might shift to one side. So one of the things that you want to do is make them pee or go to the bathroom if it's not midline. And if their bladder's not full, that could be indicative of bleeding, okay? Involution or the shrinking of the uterus is also going to cause contractions, okay? Um, it's going to be more common or more painful in women who've had multiple babies. Also as well during breastfeeding, because the oxytocin that they're going to get is going to increase contraction, which could increase pain after birth. So we can give them ibuprofen and NSAIDs and things like that so that they could tolerate their pain. And the uterus should not be palpable 2 weeks post-delivery, right? So it's going to go down 1 centimeter every day, but if it's still palpable after 2 weeks post-delivery, that's a problem. Another thing we're going to look at is lochia, which reflects the bleeding. Here we go. So rubia or red blood is what we expect to see from day 1 to day 4. Know these days because she's going to ask it like that. The next thing we're going to look at is we should see blood with clots. That's something else that we could see. It doesn't have to be seen, but it could be there, as well as characteristics of like odor, like odor of flesh that kind of smell like that. Because remember, they're still like very raw post, delivery, but we expect red blood in days 1 to 4. Days 3, 4 to 10, so 4 to 10, it's going to now be pinkish brown. We want the color to go from red to pink to brown to something called alba. After day 10, it's like a yellowish white color. They're no longer bleeding. Now, here you could see on the right different pictures of like types of staining or the amount of staining. Once again, if they're in days 1 to 4 and you see red, that's okay. But if they're saturating 2 or 3 of those pads in 1 hour, they're hemorrhaging. Okay? Problem. If they're on day 6 and they're having red blood, they're hemorrhaging. We need to do something. If they're after day 10 and they have red blood or they have pinkish brown blood, that's a problem. That's not indicative of normal healing. So 1 to 4 red, 4 to 10 pinkish brown, after day 10 yellow. Any questions? Okay. So, and another education point that I'd like to point out is that no tampons during this whole, them with the lochia, the bleeding, the 2 weeks. Make sure they do not insert any sorts of tampons. Okay, just no, we don't want anything in there. Perineum, we already talked about, right? They can have an episiotomy, they can have lacerations, right? So we want to assess for something called RETA. So it's redness, edema, ecchymosis, discharge, and approximation of suture lines. So 1, it should be redness, but it could feel warm to touch, okay? That could be a problem. Okay, we want to look for edema. If they have edema and it would be indicative of infection or hematuria. Also a problem. If we see ecchymosis, that could mean vaginal trauma. If we see discharge, depending on, like I said, if we see red bleeding on day 6, that's not normal, okay? So that's what we're looking for, RETA, and as well as approximation of suture lines. If they have an episiotomy and if, we have to suture them up after, it should be well aligned without any gaps, okay? Should look good. If not, that's a problem. So we're looking for this. We're looking for RETA in the perineum, right? Mild edema, minor bruising, mild pain, fine. Excessive swelling, infection like foul odor, pus, hematomia, bleeding, bad. So that's why we use this to assess what's going on. We also want to look at comfort measures, right? So ice packs for the first 24 hours after delivery. Sitz baths, right? So that's, I don't really know how to explain what that is, but basically it just helps with swelling. We can give them a peri bottle. We can do sitting measures, right? So basically we could have them lie on the side. We could have them like sit on one like butt cheek and then the other when they tend to sit, especially after an episiotomy, because remember, they're like open and cut over there. So if they're just gonna plop down on the seat, that could hurt. They should put one tush and then the other, okay? They should have topical anesthetics, dermaplast spray that helps numb the perineum, and that's really good to help with pain, as well as analgesics like NSAIDs. We want to have proper hand hygiene so we can reduce their risk for infections, okay? But some of the things I do see is ice packs for the first 24 hours after delivery, especially if they have an episiotomy, and then sitz baths after 24 hours. So we want ice in the beginning, and then after the first 24 hours delivery, we want to do sitz baths, which are like warmer temperature baths after, okay? Just know that. Okay. Cardiovascular things are going to happen there too, right? So they're going to have an estimated blood loss of up to 500 milliliters, if it's a vaginal delivery, and they can have up to 1,000 milliliters if they have a C-section. Know these numbers. She's going to ask them. Postpartum anemia would be indicative if they have a hemoglobin level of less than 11, and if they have a hematocrit of 32. Around that or less, that's indicative of anemia. So that's why we need to get a CBC after the first 24 hours of a new baby so we can look at those levels, as well as we want them to have iron, right? We need iron-rich foods, especially if they have postpartum anemia, okay? Such as meat, fish, dried beans, peas, orange juice, because remember, iron is always needs to be given with some sort of vitamin C source like orange juice, okay? And drink it with a straw because it could stain your teeth. Now, they have a risk for orthostatic hypotension, so we want them to, like we said, kind of like those blood pressure medications, we want them to get up slowly and change positions slowly, okay? Now, here's some other things. We expect excessive urination during the first 12 to 24 hours post-delivery in a hospital. So we want to also go with the patient for their first pee because they're going to be like a little, like I said, woozy. That's not going to really be good. So we want to make sure we go with them so they don't fall. They could also have diaphoresis, which is basically sweating at night, right? Usually post-discharge. So after they go home, they'll see diaphoresis, which is sweating at night, which is due to these decreasing estrogen levels. And we want to warn the patient that the first few nights they're home, they're going to have that. So in the hospital, first 24 hours, first 12 to 24 hours, they're going to have a lot of urination. That's okay. When they get home, tell them, hey, we expect for you to see a lot of night sweats. Any questions?
Yes, Alicia, I have a question about um wait, where are you?
I'm right here.
Right. So for the excess plasma volume, right? When they have too much plasma volume, that means their hematocrit is low, or is it the opposite of each other? Because that'd be confusing me.
What do you mean? Do you mean is this being caused by the hemoglobin levels?
And the hematocrit level. I want to know if like the hematocrit, when your hematocrit is low, does that mean that your blood plasma is more or is less?
So, actually it would be reduced. So since they're having loss of circular volume, right, we could expect that their hemoglobin and hematocrit to decrease as well as their plasma volume to decrease. They could be related to each other because remember, plasma is all the red blood cells, hematocrit, and hemoglobin. They're all the same thing. Plasma is red blood cells,
And
hemoglobin.
okay.
Yeah, so basically when you have the lower that, you also have reduced plasma volume. But just because you have reduced plasma volume after delivery does not mean you have postpartum anemia. That could happen too, but doesn't mean they have to happen. But 100% when they go when they deliver, they're going to have excessive urination and they're going to have diaphoresis. Now, if the plasma volume is reduced so much, it could lead to postpartum anemia. But doesn't mean they will have it. This is just a potential complication that they could have as well that we could see post-delivery. Okay. So, we also have urinary changes. We talked about they're going to void within the first 24 hours. They're going to pee a lot, right? We need to measure them, right? They should have 300 ml within 4 hours of delivery. 400 milliliters, this woman should pee within 4 hours of delivery, okay? If not, they're at risk for postpartum hemorrhage, as well as potential urinary tract infections, and as well as they're going to have a lot of, urination within that 12 to 24 hours. They must void 2 to 4 hours after delivery because of the problem of postpartum hemorrhage, as well as they could have incomplete bladder emptying and inability to void, which could be a problem, okay? We also have, I don't really think she put an emphasis on GI, just know they're also at risk for like constipation and hemorrhoids because of progesterone and things like that. Okay, next we have lactation. So we have, that means, that's the secretion of milk by the breast. As soon as the placenta separates, they're going to lactate. That mom is going to lactate as soon as the placenta leaves. This is just an interplay between prolactin, oxytocin, estrogen, progesterone. All of those hormones are coming together to produce this. So we have breastfeeding, right? Which is the preferred type of nutrition for a baby. There should be coordinated mechanisms to the breastfeeding. So they should have periodic motions by the newborn's jaw. There should be movements by the baby's tongue, or called undulation. And the breast milk, there should be an ejection reflex. Breast milk should come out when it feels like the baby's presence of, sucking on the nipple. So here's the thing. Um, when there's 6 months of that baby being born, we really don't um want them to be doing breastfeeding or any of that anymore, just for the first 6 months of life. And in order to promote breastfeeding and to initiate breastfeeding, we need to have skin to skin contact within the first hour of delivery. Okay, that helps promote breastfeeding. Also, here's another problem that can happen. If, let's just say, post, delivery, maybe the mom doesn't want to breastfeed, or, she's breastfeeding, a complication could be engorgement, which is distension and swelling of the breast tissue as a result of lactation, right? And sometimes you could have engorgement, like I said, as a result of not breastfeeding. So, and because the body isn't able to remove that lactation, so as a result, it's just like filling up there and making the breast really heavy and full and swollen, and it hurts. Um, and and that's why it's caused, right? Because it's not being fully emptied. The breast milk is not being fully emptied, either by the infant not getting enough, or giving the baby enough at each feeding and leaving too much in the breast, causing swelling, pain, all of this uncomfortable stuff. So here's the thing. Engorgement is a problem. We can see this day 2 to 3 after delivery. That's when we typically see it. Not the first day, the second to third day, we can see this after delivery. If we want to promote breastfeeding, right? We want to promote that, especially if they have engorgement, right? And we want to promote it. We want to empty the breast frequently, right? We want to make sure the baby's being fed a lot. We want to position the baby properly, so they need to latch onto the areola, not the nipple. They need to latch onto the areola part. Manual expression, right? We might need to actually like press on it a bit to help stimulate it to get it out, right? You have to press on the breast itself. They should have warm compresses. That's going to help stimulate and soften the breast to help actually allow it to come out. Um, Also a supportive bra, not a tight fitting bra, a supportive bra. And cabbage leaves. I don't know why, but cabbage leaves can help. If you put them in the bra, they can help with engorgement. All of these actions are going to stimulate breastfeeding for a mother who wants to breastfeed their child. If they're getting engorgement and they do not want to breastfeed their child, we have different mechanisms. So we need to avoid all stimulus of the breast, such as no infant like sucking on the areola, right? We need to suppress breast milk development. Okay. So they could still have, a little bit of leakage that can come out of the breast until it ceases, but the goal is to cease, right? So no stimulation, which means you can't shower with water facing the breast. You need to shower with the back, get no water on the breast, because that's going to stimulate it, right? Because warm water is going to stimulate the breast. Okay. No warmth, ibuprofen to help with the pain, ice packs, right? Warmth helps promote um breastfeeding. Ice packs is going to diminish that. Okay. We want to avoid any sort of stimulation, and a tight supportive bra 24 hours a day. For someone who does not want to breastfeed, for someone who does, we need a supportive bra. Any questions about that?
Alicia, does a person lactation could it also be like a mom who wants to breastfeed, but they have so much, so they also want to suppress it. They don't always have to be the one who don't want to breastfeed.
Usually it's just in situations for people who don't want to breastfeed, because there's only two ways that you could help engorgement: either actually like breastfeeding or not breastfeeding. Because if they don't breastfeed, they're gonna have engorgement on day 2 or 3. Now, it could be, a situation where, like you were kind of mentioning, I think the way I understood it was that they're trying to breastfeed, but maybe not everything's coming out. That's what would lead to engorgement. But the only way that engorgement can go away is either you stimulate it or you don't do any sort of lactation at all. And that's usually in mothers who don't want to lactate and they're getting the problem of engorgement because of that. They'll have to do these things. Does that answer your question?
Thank you.
Okay. All right, awesome. Yeah. So yeah, it's just that's the problem with engorgement. It's like all this swelling that's happening. I mean, either we need to stimulate the breast so we can continue to breastfeed, or we need to suppress it to prevent the engorgement. Okay. Now the last thing is the recurrence of ovulation and menstruation. She's going to ask this. For non-breastfeeding mothers, okay, you expect 8 weeks after delivery, right, to have some sort of ovulation come back. Ovulation is going to come back in 8 weeks after delivery. All periods must resume within 6 months. So within 8 weeks of delivery, so after that 8 weeks of delivery, we're going to see ovulation and menstruation come back, but they must resume within 6 months. And patient education for them would say, hey, you're going to ovulate before getting your next period so you can get pregnant, okay? Even within those 8 weeks of delivery, right? Because after 8 weeks, you can get pregnant. So you have to be very careful, right? Um, as well as, making sure you tell them you must see a period by 6 months. You could see it as early as 8 weeks after delivery, but you must see it within 6 months. Breastfeeding mothers, right? It really just depends on how long they breastfeed. The longer they breastfeed, ovulation is going to stop and menstruation is not going to really occur as much when they're breastfeeding. Isn't that kind of interesting? Depending on the length of time they breastfeed and the frequency of breastfeeding, it actually prevents ovulation. So you can't get pregnant while you're breastfeeding. It's very hard. Whereas if you're not breastfeeding, you can get pregnant as early as 8 weeks after delivery. But for example, right, if you're a working mom, it might be hard to breastfeed for the suggested 6 months or whatever. So definitely, non-breastfeeding would be, I think, a typical response for majority of people. But yeah, those are those things you need to know because she's going to ask about them. So the next thing is chapter 16, nursing management during the postpartum period. Is there any questions about any of the postpartum adaptations? Okay, so chapter 16. What are we talking about? We're talking about nursing management during the postpartum period. So what do we need to look for? Vital signs, right? We want to look at the maternal temperature, right? If it's up to 100.4, that's normal for the first 24 hours post-delivery. We want to encourage fluids, right? They also have risk, for dehydration after delivery and a leukocytosis, which is the increase of white blood cells. If that temperature gets higher than 100.4, within that first 24 hours post-delivery, notify the doctor. They're having an infection. They could have pregnancy-induced hypertension, which can persist or occur in the first time of that postpartum period. So we're looking for signs of preeclampsia, right? So they, we talked about how they could be confused, they could have problems with urine output, they can have those skin changes. So make sure that we, look for those preeclampsia signs that we spoke about before, as well as there could be decreased fetal movements, right? All of these sorts of problems. The heart rate should be 60 to 80 beats per minute at rest. Okay. The pulse, if it's greater than 100, there's a problem. So we want 60 to 80. If it's greater than 100, they could be at risk for hypovolemia, pain, infection, and hemorrhage. Respiratory rate should be 12 to 20. Also, we need to compare the blood pressures, right? Speaking about potentially pregnancy-induced hypertension and looking for preeclampsia, we want to make sure that we know what her baseline was before, so we know if this is normal. And we can ask about pain using the old cart mnemonic. So these are all the sorts of things we want to look at when the mom delivers in terms of vital signs: blood pressure, heart rate, this, that, temperature. Now, another thing that we want to do when it's post-delivery is we're going to do something called BUBBLEE. which is a focused assessment. The B, the first B stands for breast. So remember, we talked about engorgement that we see 2 to 3 days after delivery and certain interventions that we need to do in order to either continue and promoting stimulation of breastfeeding or prevent lactation at all, right? So, remember, engorgement is that tenderness, that full, really heavy feeling. We also want to assess the nipples. We want to look for irritation and tissue breakdown, blisters, cracks, okay? We want to look at comfort measures. We already talked about what comfort measures that we do for someone who's breastfeeding versus someone who doesn't want to breastfeed. So think about those things, right? When we're talking about how to either stimulate breastfeeding and how to not stimulate because of engorgement. So I'm not going to repeat those. But yeah, like I said, if they want to breastfeed, we want to have a supportive bra, warmth, stimulation. If it's, non-supporting and we don't want to breastfeed, or that mom doesn't want to breastfeed, we want them to have a tight bra, no stimulation of the breast, all those things, and using ice packs, right? That U in BUBBLEE stands for uterus. Uterus is your priority assessment. Priority, priority, priority. Okay, so postpartum, what is your priority? The uterus assessment. You want to look at the fundus. It should be at the level of the umbilicus. It should be firm and it should be midline. Okay, once again, I already said that the bladder can turn it a little bit and move it to the side. So we want to have them go to the bathroom because that could be why it was moved. But if that was not the reason, they're at risk for hemorrhage, okay? Uterus is the priority assessment. Then we go to bladder, right? They need to avoid, we already said this, within 4 hours of delivery and at least 300 milliliters within that first 4 hours. They're going to have diuresis. Remember, we said they're going to have a lot because of that reduced plasma volume, which begins 12 to 24 hours post-delivery, right? We don't want them to have any voiding problems. Like, we don't want them to have pain. And like I said, a full bladder will displace the uterus to the right. So that increases the risk for postpartum hemorrhage. That's why we need to make sure they pee. Okay, the next thing is bowels. They should have a normal bowel pattern within 1 week of delivery. We want to assess bowel sounds and avoid constipation, right? So we want to give fluids, fruits, lots of fiber foods, exercise, things like that, and no cheese because excessive cheese can cause constipation. We already talked about lochia. So we talked about the BUBB in BUBBLEE. Now we're on the L, the lochia. So the lochia, we already said the amount, the color, the odor, right? If they're saturating a pad within 1 hour, that's heavy. That means, uh-oh, they might be hemorrhaging. You need to remember the stages of what the lochia should look like, right? From day 1 to day 4, it's red, rubia. From day 4 to 10, it's like that pinkish brownish color and it's decreasing in amount. And then in day 10 and up, it's going to be like that yellow, that alba color, that yellow whitish color. And it's going to be little to no saturation on the pad, right? Of that particular color. Now we need to also remember the lochia is like blood. It's like a period, right? So you need to frequently change the pads to prevent infections, right? Now here's the thing. If there's excessive bleeding, right? And you see that in the lochia, let's say they're saturating the pad, two or three pads within 1 hour, your priority is to massage the boggy fundus. When they're bleeding, the uterus is going to be boggy. It's not going to be firm. So if we have a boggy fundus, we need to massage it. That's your priority intervention because that's going to reduce the flow of blood. Okay? Any questions so far? Okay. So like I said, priority is that uterus and checking if it's firm and it should not be boggy. If it is, we need to massage the uterus. That's your priority intervention post delivery. We also have, like I said, now we're in the BUBBLE, that first E, which is the episiotomy, right? So we want to assess for RETA. We already said that, which is redness, edema, ecchymosis, discharge, and approximation, right? We want to promote comfort measures. We said cold and ice packs for the first 24 hours delivery and heat after the first 24 hours through a sitz bath or peri bottle, which is warm tapped water. We can give topical applications like benzocaine, and we can give Tux, which is witch hazel for hemorrhoids, all of these things to promote comfort in the perineum, as well as stool softeners, right? And we also want to look at the epidural site. If they had one, right, look at it. Make sure there's no signs of infection. So that next E, so we said epiostomy, then it's BUBBLEE. The second E is extremities. So we want to look for any signs of DVT, right? So you want to take your hands, run it up the calf, look for warmth, redness, edema, and pain. And we also want to assess for sensor and motor function, especially following an epidural. Remember, it blocks spinal nerves. So we want to make sure that they have motor and sensory functions. Can they feel this? Can they move their legs? Things like that. When I say feel this, I mean, can they feel, movement and sensation on their lower extremities, right? The next few E's include emotional status. So we need to look at their psychosocial. We want to promote bonding and attachment by putting the baby to the chest of the mom within that first hour of delivery, right? Getting out of bed, making sure that, somebody's with them. Another thing is that they can have something called postpartum blues. So we want to ask them post-delivery is, are they having pleasure and interest in things still? And are they feeling predominantly down, depressed, or hopeless? Those are indicative of postpartum blues. It usually relates to fatigue and shifts in hormones. Um, they have joy and they're interested in the baby, but they feel overwhelmed and they have urges to cry. If it was postpartum depression, they wouldn't have joy or interest in the baby. Just, I want to explain the difference. But postpartum blues, they do have joy and they are interested in the baby. It's just that they're really overwhelmed and they cry a lot, okay? So they need a lot of assistance here. Okay. The next thing is that we want to look at elimination patterns such as the bladders, the bowels, activity, rest, and exercise, right? Bladder, they should be peeing. We already talked about how many times they need to pee. They need to have good bowel movements. We want to avoid constipation. We want activity and rest. And we also want to make sure that, you know, the woman has a choice for the infant's feeding, right? What do they want to do? Do they want to breastfeed or not breastfeed? Oh, also, don't forget, if you didn't put your SFC ID number into the chat, please do that for me. I forgot to mention that earlier. But anyway, okay, so back to this. We talked about BUBBLEE. That is basically this whole big thing, which tells us the focus assessment of what we need to do when a mom gives birth, but the priority assessment, we want to look at all these things, but the priority is the uterus. And if the uterus is boggy, we need to massage it as indicative of bleeding. Okay. Any questions about the assessment? Okay. So the next thing is preparing for discharge, right? When we want the mom to leave the hospital, we need to make sure that uterus is firm. We need to make sure that they have appropriate lochia and color and amount for the day, all of that stuff, right? We want to make sure they're afebrile, they don't have a fever, and everything, the vital signs are within normal limits, that their hemoglobin and hematocrit are within normal limits, they have a good urine output. The surgical wound should show no signs of infection. I see a hand raised.
Alicia, so in this lochia stage, Pitocin wouldn't be the first priority. Massaging will be the first priority. If the patient is bleeding, is having excessive bleeding, instead of giving Pitocin as the first priority, we're going to massage the fundus until it becomes firm.
Yes, if the question says that the mom has a boggy fundus, what should you do? Massage.
But what if it's because over here it says if excessive bleeding occur, the first step will be to massage the boggy fundus. But I want
Yes.
to know if the question is asking us, or the patient is having excessive bleeding, what will be your first priority? Will it be to give Pitocin or to massage the fundus first?
Massage the fundus.
Okay.
Pitocin is given after delivery to help reduce postpartum hemorrhage, but if they actually begin to bleed, you have to massage the uterus.
All right.
Okay. Okay. So yeah, like I said, we're looking for all of these things. We also want to look at the blood type and RH factor before, remember, because we said that we want to make sure that with those Coombs and direct Coombs, right, we want to do the direct Coombs on that baby before they leave, right? If the baby is RH positive and the mom is RH negative and no antibodies were formed, then we're going to give them Rogram. within 72 hours delivery if the direct Coombs is negative. If it's positive and there's sensitization, like meaning antibodies formed, there's nothing you could do, and just hope in the future deliveries that the baby isn't Rh positive and that there's no complications. We also need to give rubella vaccine. Something that we're looking for is that if they're not immune, the mom, they need to get the vaccine within after 4 weeks. Not after, before 4 weeks of trying to get pregnant again, because the measles, mumps, and rubella vaccine can actually have like negative effects on the growing fetus. So if the mom is trying to get pregnant, down the line, and she's like, hey, I want to get the vaccine, they must wait 4 weeks before trying to get pregnant again. And another thing that I know that she does ask is, how do we know if the patient is immune or not immune? Well, it should say 1-8 ratio. The titer should be 1-8 ratio or greater. If it has 1-8 or greater, that means they're immune. If it's lower, they're not. If they're not immune, as I said, we have to wait 4 weeks before getting pregnant again if we want to take that vaccine as a female. If we tell her that, she has to know you can't get pregnant for 4 weeks if you get the vaccine. Okay. So, oh, and just remember that, you also give hepatitis B within like the first 24 hours of delivery to the baby. Okay. So, chapter 22 is the nursing management of postpartum women at risk. So, we talked about postpartum hemorrhage. We're going to talk about it again. Postpartum hemorrhage is when we have an estimated blood loss of greater than 500 milliliters for a vaginal delivery or greater than 1,000 milliliters cesarean. Remember, we said normal is 500 or less, and 1,000 or less for cesarean, or 500 or less for vaginal. If it's greater than those amounts, they're at risk for postpartum hemorrhage. What also are risk factors, right? They have a large baby, if they have multiple gestation, they had twins or triplets, they have a multi-parity, so they had like 8, 6, 5 kids before, whatever. The labor is more than 2 hours, right? They have magnesium sulfate, or they had polyhydramnios, which is basically when they have the increase in that amniotic fluid. If they had that during the pregnancy, that could also cause postpartum hemorrhage. So, other causes, right? These are risk factors that can cause postpartum hemorrhage, but these are the primary causes. So, these are all risk, but primary causes are the 4 T's: tone, tissue, trauma, and thrombin disorders. Tone, uterine atony, right? This means when the uterus fails to contract and there's a descended bladder and it's going to be boggy, okay? The tissue, there's going to be retained placental fragments. If the placenta didn't fully come out of the uterus, that can cause postpartum hemorrhage. If there's trauma, such as lacerations, hematoma, rupture, anything of those, that can cause postpartum hemorrhage, as well as thrombin disorders, meaning if they have DIC, or they have clots that are forming, but they're not big enough to actually stop bleeding, they're at risk for postpartum hemorrhage. And those are your 4 T's. Okay, so we talked about, right, lacerations that can cause postpartum hemorrhage. They're most common after an operative delivery. Okay, the uterus is firm, but there could be copious amounts of bleeding. That's what you want to know. If you have a laceration of the perineum, the vaginal, the cervix, and it's an operative delivery, the uterus is going to be firm, but there's going to be a copious amount of bleeding, but it's not going to be the way you would think. It would not present as boggy, right? But the uterus is still going to be firm. Okay? There's also going to be a steady stream of blood without clots from the vagina, and it's going to be bright red from the tear. This requires repair, and we need to notify the doctor. Okay? So that's what I want you to know, right? Is that for someone presenting with an operative delivery, the uterus is going to be firm, but there's still going to be a lot of bleeding. It's not going to present as boggy. Okay? That's different, okay? Whereas, like I said, normally you would see saturation of the peripad and the uterus remains boggy. That would tell you, okay, they're also bleeding. But for someone who has a laceration of the perineum after some sort of operative delivery, right, the uterus can be firm. And there's different degrees of the laceration. So the first degree is superficial. So there's like the vaginal mucosa is torn. There's a second degree laceration, which is there's a tear into those perineal muscles. The third degree laceration is a tear into the anal sphincter. And the fourth degree is actual tear into the rectum. So that's the degrees of laceration of the perineum. But like I said, the uterus is still going to be firm, but they're going to have a lot of red, bloody stream from the vagina. Hematomas is another type of problem that they could have, right? It could be vulvar, vaginal, or retroperitoneal. Basically, this patient is going to present with deep, severe, unrelenting pain. That's going to let me know that they have a hematuria. The peripad won't be saturated. The uterus is firm, and the lochia is going to look normal, right? So it's going to have the right amount of lochia. It's not going to present as abnormal. The peripad is not going to be saturated. The uterus is still going to be firm. It should be boggy, but it's firm in this case. And they're going to have deep, severe, unrelenting pain. That's going to let me know that they're having a hematuria, right? And there's actually bleeding, but it's more of an internal bleed. That's why the peripad is not being saturated, okay? So if you see these things, we know we got to think hematoma. If we see, the uterus is firm, but they have a steady flow, like a lot of flow on the peripad, laceration, okay? If we see, right, regular boggy uterus, bright red, we know that's postpartum hemorrhage, but these are different types. It could be caused by a laceration or a hematoma, and you need to know the different types of presentations for them because she's going to ask you about that. And like I said, a normal assessment would be, a lot of saturation of a peripad, let's just say within like 15 minutes of delivery, and the uterus is boggy even after a fundal massage, okay? But if the uterus is firm and there's copious vaginal bleed, we got to think laceration. Okay. So, nursing care, if they have postpartum hemorrhage, what is the priority intervention? Massage that boggy uterus. You take the non-dominant hand to support the pubic bone, and the dominant hand rubs in a circular motion on it. Okay. Remember, we have to encourage voiding because voiding can increase postpartum hemorrhage. So if they have that full bladder and they don't void, we have a problem. That's why we need to make sure we check the bladder, we make them void so we decrease the risk of postpartum hemorrhage. We need to consider laceration if it's a firm uterus, okay? We also need to increase the IV fluid rate, right? Because they're bleeding. Now, the second priority is to assess vital signs because we need to check for hypovolemia, okay? So first priority, massage the boggy uterus. The second priority is to assess vitals, okay? If they have hypovolemia or signs and symptoms of hypovolemia, we're going to elevate the legs 15 to 30 degrees if they have hypovolemia. Okay, so those are the things that we need to think about. Okay, now another thing is that we need to look at medical management, right? So we can give medications, right? Especially if the fundal massage is just not helping with the bleeding, right? We can have a bimanual compression of the uterus. We could do all of these things, but you need to know the nursing care. You need to know these interventions, what you do first, what you do second, right? Now, pharmacological management. What kind of medications? We talked about this, right? Somebody asked about IV Pitocin, right? So we can give IV Pitocin. Remember, we said that was the standard after the placenta is delivered. That helps with decreasing the risk for postpartum hemorrhage. That's one thing that we could do. We can give methyljovenone. I don't know how to say that, but it's an IM injection, which is going to cause vasoconstriction, but it's not uterine specific, and it cannot be used with hypertensive patients. So this medication we can give to help with postpartum hemorrhage, but we can't give it if someone's hypertensive. That's going to be your key of determining if you're going to give this medication or not. Carboprose is also an IM injection, but it can be used in hypertensive patients, but you can't use it in patients who have cardiac, pulmonary, renal, or hepatic disease, okay, especially respiratory and cardiac because it can cause complications. So yeah, it's great. You could use carboprose if they have hypertension, but the other one, methylgynovine, I don't know how to say it, cannot be used in hypertensive patients. But you could use this one, methylgynovine, if it has a patient who's like asthmatic or has a pulmonary problem, but you couldn't use carboprose if they have a pulmonary problem. Misoprostol is another thing that we can give. You can give it rectally, right? Contraindications is that you can never give it as an undiluted bolus injection, okay? You also can't give it to someone who has an allergy or an active cardiovascular, pulmonary, or hepatic disease. And we also need to use in caution with asthma, okay? Misoprostol, not very good with asthmatic patients. So we know that carbaprost and misoprostol, not good with pulmonary problems, and misoprostol specifically with asthma. Know these things. And I would know the specific amount of IV Pitocin that you give 20 to 40 units in 1,000 milliliters. Okay. The newest recommendations, if they have uterine atony, remember the uterus is not doing what it's supposed to do. It cannot contract. Okay. So if that's the case, right, and it's not contracting, right, we need to give a combination of oxytocin and misoprostol. That's the best combination, especially in reducing the frequency of postpartum bleeding in a loss greater than 500 milliliters. Okay. And the misoprostol dose will give 200 to 600 micrograms. Um, Okay, the last thing I'm going to talk about is this, which is the postpartum infection. So, something that you can get, we said postpartum hemorrhage is a problem. We talked about the management, we talked about medical and medications that we can give. Now we're going to talk about postpartum infections. Now, a postpartum infection that we can get is something called mastitis, which is an inflammation of the mammary gland, which occurs between the first 2 days and 2 weeks postpartum. Okay, you need to know when it occurs. So, the first 2 days and 2 weeks postpartum. Somewhere between that time, they could have this. And basically, it's an incomplete emptying of the breast or stasis of the milk. The milk is not going, and if they're not fully emptying the breast, they can have this. Okay, and it also can be due to poor positioning of the breast. So, in other words, they're not properly, right, latching the baby onto the breast to ensure proper positioning. If there's no proper positioning when the baby is trying to get the breast milk, that can cause skin breakdown on the nipple and cause metastasis. Okay, they can have an infection or inflammation of the mammary gland. How do we know if they have it? Well, we'll see on assessment findings, right? That they have unilateral breast pain, warmth, redness, and arrhythmia in one breast. Okay? Whereas we wouldn't see bilateral breast pain, okay? Be unilateral. And they're going to have flu-like symptoms. So they're going to have fatigue, muscle aches, elevated temperature chills. Think it's an infection, it's an inflammatory response. Okay? So we need to think about fever, chills, things like that, right? Now, management, we want to reduce the risk, right? So we need to make sure they have complete emptying of the breast. This is for management, right? This is for reducing the risk for it. So if they don't have metastasis, we could tell them we need to monitor and tell our moms, hey, you need to empty your breast completely or else you're at risk for this, right? The baby should be on each breast for 15 to 20 minutes to ensure proper emptying. That's how long you should keep the baby there. There should be proper positioning, like I said, on the areola, not on the nipple. You need to have good hygiene, right, to prevent any sorts of infections, as well as keeping the nipples from getting dry and cracked because that's what can cause an infection to come in, as well as manually compressing some breast milk and rubbing on the breast, on the nipple to help stimulate and make sure everything gets out. Now, if they have metastasis, right, if they have we want to treat it by emptying the breast, like we said, and controlling the infection. So we need to pump the breast milk now because the issue is that we can't give the breast milk to the baby the way it is because it's infected. So we don't give that. We have to actually pump the breast milk. We have to tell the mom to do that, as well as give cephalosporins like Caflex or cephaloflexin. And examples of cephalosporins includes cefalor, cefalexin, and ceftriaxone. All of those are different types of cephalosporins. I always think of E's, either CEF or CEPH. Those are always cephalosporins. And those are going to help, especially because, like I said, it could be caused by bacteria and things like that. So we want to make sure that we treat the infection.